Hi, colleagues in the Netherlands. Nice to meet you. Apologies, I can't be there today. It's the Queen's Jubilee celebrations in the UK, so I will be probably eating lots of cake and having some tea, as we do in England, and raising a glass to the Queen. But this presentation is on the vision for One London and the use of openEHR and services to support the structured capture of information and the creation of a clinical data repository for London. So what I'll do is I'll take you through how we structure ourselves in London, a bit about our program, and then why better and why openEHR towards the end. So I'm the Chief Technology Officer for London. My name's Gary Mcallister, and my role is really to support London to create platforms and services through the use of standards to provide interoperable solutions, enabling information exchange and digital maturity, so promoting and kind of endorsing digital maturity through a supportive approach across London. I do that personally through the creation of data standards and interoperability standards, which then enable things like the transfer of care. And then we purchase platforms such as Better to enable data in a structured form to flow between care settings to enable more optimized and streamlined pathways. So more on our approach. So the One London approach has always been based on three levels. We've been running our program since 2018, but the kind of focus up till now has been on level one, which is our information sharing strategy. And that really is using health information exchange standards to support the flow of documentation through clinical portals available at the point of care, so that data can be available and is exchanged through all care settings at the point of care. So you've got primary care, which is general practice, secondary care, which is the acutes, mental health, social care, and community services, all sharing data at the point of care through our information exchange, which has transformed the way that we deliver care. You know, cancer patients no longer have to repeat their story at the point of care, and primary care information is then available in secondary care, so you reduce any errors in the process of delivering care. So allergies are always available, existing prescriptions are always available. So care just becomes far more safer. But what we're doing now is moving beyond that into what we call our level two. So the creation of a clinical data repository supported through the Better platform using openEHR to enable us to create data standards, which then enforce the use of those data standards at the point of care to enable secondary use and then the sharing of information more readily across London in a more structured form, which then enables us to create decision support rules, and also use the information to drive other workflow activities downstream, through understanding patients' needs and wishes, and then referral pathways can be automated and optimized and that kind of thing. Level three to our program was always based around patient access to that data. I think once we get towards the kind of structured data repository and we have a real canonical form of information captured and stored and available to patients, we'll be able to give patients more access and flexibility. But that is an ambition of our program, as we continue the urgent care program and then create more kind of clinical documentation available across the region. Will provide patients with access to that data, as well as their other parts of their medical records and their kind of pathway orientated records, so appointments and other factors that patients need access to, which will then make London the most digitally mature region probably in the world. We're also doing a lot of work around image sharing, which is very important to us, and we're connecting all of our image exchanges together so that we'll have a connected city from a clinical and health perspective. So why a platform approach? So we procured the Betten platform, and we were aware that it was openEHR compliant at the point of purchase. And that's really to improve the use of information in a structured form at the point of care. And I've already touched on the importance of clinical decision support, but without the use of structured data, you can't really drive safe clinical decision support. So as I said, level one to us was always about having unstructured data or data in a form that we can get access to it. So, accessing HTML information, accessing other raw forms of data in documentation format that doesn't allow you to create decision support rules or secondary use tasks or downstream workflow. And that's really what this is about to us. But in order to do that, you have to have well-formed archetypes or well-formed data standards, which means that the data is always captured consistently at the point of care. And then if we do that in a platform orientated way, everyone is always capturing the same information in the same format, which then means that we can trust that information and use it safely for other purposes. So that's why platforms are important, because they drive consistency and they drive optimized use of information, not just at the point of care, and they make information more readily understandable because the standards are consistent, but also downstream we can then drive some efficiencies through having information far more accessible and standardized. Um, Data is everywhere as well. Data is proliferated throughout the NHS. A lot of it is dirty and unusable. So even the primary care records that we've got that have been running for 2 or 3 decades now, the data within there is very variable. We were the first, I think, standards-based primary care system possibly in the world using read coding. But because of the way these clinical systems work, they don't really enforce the use of the systems themselves. So as an example, there's nothing stopping a GP using the note to capture an immunisation in unstructured form, which then makes the record dirty, doesn't make it consistent. And we want to try and reduce the errors in the information repositories that we have available to us. So again, openEHR supports that, and it helps us through a data first approach to making sure that as we generate archetypes, those archetypes are enforced through the better platform, captured consistently with the right values, and again to drive a better use of information. So that's really what this is about. It's improving the quality and efficiency of care through workflow driven activity downstream, but also making the safety and effectiveness of care far better at the point of data capture, and also improving user experience. Some of these systems that we've got available to us at the point of care aren't very nice to use. They're legacy, and the better platform improves the user experience and drives a change of use, if you like, through people actually enjoying the system that they're using at the point of care, rather than having something that feels old and not very modern. So what we're doing first is we've decided to use end of life and what we call urgent care planning first. That's really because we already had a system that was, again, it was a good system, very well written, if you like, from a development perspective, and it looked nice, but it didn't do some of the things that we needed it to do. It was quite rigid. It was managed by a supplier. It wasn't open, so we couldn't really access the data very well. So we decided to replace that. And when we went out to tender, in all honesty, we didn't think an open EHR system would be the answer. But as we've gone through that procurement and working with colleagues in the better team, open EHR really will give us a lot of benefit, because it's by specification is an open ecosystem, which means as you create an archetype, there's APIs available for it. The data that's captured is consistent, and it gives us a real level of flexibility when it comes to creating other care plans or other, clinical documentation downstream. So that's really important to us, to have a flexible platform that is open. But the care planning platform itself and our program is highly complex. It's lots of integration. We've got 30 acute organisations in London, 1,400 GP practices, about 10 to 15 mental health organisations, and equally about 30 community organisations as well, when you include charitable organisations that support community services. So highly complex health system, and what we're doing is we're embedding better within those clinical systems to drive access to the system from the point of care in context of the patient, which then means that the capture of information is always safe. In England, we've got the NHS number, which is brilliant. It's a single identifier, and there's a national service that provides that capability, and the better team have hooked into that, which means that the demographics for an individual will always be captured safely. But as we progress and move forward, what we want to do is use that primary care record in a structured form pull that information into the end of life care plan to reduce duplication. Equally, as I've just described, we want to reduce the amount of logins that GPs and care practitioners and nurses and other specialist clinical staff have to use in order to access these services. So through working with the Better team, we're doing all of the integration to integrate directly with these clinical systems that exist within London, as well as providing a portal that can be accessed using traditional username and password mechanisms to allow clinicians to access the data in a nice, as I say, modern way. Um, but this really supports, end of life patients, um, provide their care practitioner with their wishes at the end of their life. So it's a very important piece of the jigsaw. And then as we move forward, we'll most likely look at mental health care planning next, creating archetypes of mental health care plans. Because there are some patients, unfortunately, that their wishes aren't met. One of the stories that I use often is that a mental health patient can present at the side of the road. Um, they could have overdosed, but because the services don't have access to their records, they don't know that they're a mental health patient. And there's been cases where mental health patients have been presenting at the side of the road or in an emergency situation for them in crisis, and just been deemed to be drunk and sent home, and unfortunately have passed away because they'd had an overdose. These information sharing systems prevent those types of scenarios from happening, because all of the services, emergency services, ambulances, A&E departments, they all have access to the record. And equally, as a patient on the end of your life, you want to die comfortably, and you want to end your life with your wishes met in the most comfortable, peaceful way possible. With your family, probably by your side, in the comfort of a surrounding that you've chosen. And that's really what this is about. It's about respecting an individual's wishes at the end of their life. Um, Again, care planning involves multiple organisations and multiple agencies. I've touched on that already, but care plans can be accessed from primary care, secondary care predominantly, but end of life care planning and care planning generically supports things like the transfer of care. So if you're an ambulance, you can transfer a record from the paramedic to emergency departments, which then supports the ability for organisations to move patients around more seamlessly. If you can imagine a stroke patient being picked up at the side of the road with a care plan being captured on an iPad through the paramedic, that then can transfer to the emergency department, and that patient will automatically be admitted with clot busters or any type of medication needed to help that stroke patient be treated far quicker than going through a traditional gated process, which doesn't have an information flow associated with it, where you have a paper record and radio communication, or a red phone communication to the emergency department to expect an admission for a stroke patient. That's old ways of working. Now with electronic distribution of information, that stuff should automatically happen. The individuals involved in the process should be focused on the patient and caring for the patient, with the knowledge that the information will automatically flow to secondary care, supporting downstream activities. And then when you talk about shared therapeutic plans, having that ability to share information between, the therapist and primary care, so that when the patient represents at primary care, they're aware of what physio patient's having, of what home adjustments an individual has been prescribed through occupational therapy. Um, and all those other things that go around and associated with, just an example, we have we have hospice networks in London, where there's a southern and a southern network and a northern network. At the moment, that those forms are all captured on paper using Word and are sent using email to hospices who are treating for end of life, pediatric patients. And through the Better platform, we plan to change that. We create an archetype for a referral, which then supports a pediatric referral at the end of their life from, a clinical organisation such as Great Ormond Street Hospital or the Evelina Children's Hospital, and then we move them to the appropriate hospice to have their wishes met at the end of their life. So where have we got to? You've already heard that we've chosen Better. We've enjoyed the process of working with them so far, our program aims to go live July, August time, and we think we're going to meet that. It will be integrated into primary and secondary care at the point of go live through our health information exchange, which is available through primary care and secondary care through a document transfer. We've designed a very beautiful end of life care plan, which we believe will solve a lot of problems for us, and will be better than the one we had previously. Excuse the pun. Um, we plan to integrate it with the NHS app, which is a patient-facing application. And then as we move forward, you've already heard about us and what we're doing with our mental health data standards work, and also some of the referral pathways that we plan to tackle in London through the development of archetypes. But what we really feel now is now we've got our partner with Better and we're using openEHR. The world is our oyster. We'll have an open platform to support what we need in the future. We look forward to the journey that we're on, and we're actually quite excited about where this leads as we move forwards. I wish you all well in the Netherlands. Thank you very much for listening to me. Enjoy the rest of the conference. I think Ian McNichol is going to be there to take some questions around the awareness that he has of the London programme. If you can have a cup of tea and a bit of cake for the Queen, and I wish you all well. And hopefully I'll get to meet you in person one day. Best wishes.